Welcome. Today we're going to take a look at portable mobile radiography for both routine X-ray and fluoroscopy. Mobile medical imaging systems are used throughout the hospital, from inpatient to NICU, operating room, and emergency room imaging. Today we'd like to concentrate on those using ionizing radiation, routine diagnostic X-ray, and fluoroscopy. The last couple years, we have been going through a COVID pandemic, and this pandemic has changed many things, including how we do medical imaging in the hospital and how we interact with patients and colleagues. The biggest changes have been in bedside portable examinations. So let's look at portable imaging today. The pandemic has quickly increased the adaptation of new technologies and will change the way radiology departments work also in the long term. Some of the biggest changes have come about with personal protective equipment and also protection of the imaging equipment so that we do not transmit disease to our colleagues and patients. The implementation of these new policies and procedures have increased the time it takes to do a portable examination and also increased the cost of a portable examination. Let's take a moment to look at these images here and do a comparison. On the left, we see film screen radiography. On the right, we see electronic imaging or digital imaging. Do you see differences in not only the equipment, but in how the radiographer has to prepare themselves for each and every exam? Take a moment and look and try to count the number of differences you see between the radiographer of the past and today's radiographer. Continuing with our comparison, let's take a look at medical imaging from physiology to information. I doubt very much that you would be able to have taken a portable X-ray exam film screen that would have been acceptable to the radiologist through a glass partition on the patient's door. And yet, we're able to do that today. So we really have to understand what we're doing or how we're imaging the patient. And remember, tissue density is a static property that causes the attenuation of the X-ray. And we're looking at also different things that affect that X-ray or the main beam, which could be patient's body habitus, distance, blood flow, motion, positioning, etc. So it is more complex to be able to do a digital image and get everything correct compared to a film screen image. In reality, the physics of imaging has not changed at all. What has changed is the amount of information that we can get for each exposure and how we're able to manipulate the information on an electronic image or post-process, which we could not do with a film screen image. Capture of the image on a film screen system was rather basic. Capture of the image on an electronic piece of imaging equipment is more complex and takes more thought because of the sensitivity of the image receptor and the dynamic range of the data that can be acquired. The instrumentation used in collecting the data is one of the most important factors defining the image quality in terms of signal to noise, or how much radiation we have, resolution, or how well we're able to visualize the data that we're capturing. In addition, source specifications of the instrumentation directly affect imaging capabilities. So what we're looking at here is we have to know how the detector interacts with the ionizing radiation and what are the properties and capabilities of that image detector. In addition, we need to know if the equipment itself can generate the type of imaging data from the primary beam. Do we have enough power? Can we collimate? Do we have the distance correct? Is the patient's... All these things come into play when we do a portable examination. It takes time to set up an examination and do it correctly. Let's look at imaging data acquisition methods for electronic images. We have entire programs dedicated to just this subject, so we'll do a very brief cursory overview of digital electronic imaging. If you'll take a look to the right, you'll see the image of an elbow. That image is superimposed over an active data display image receptor. You'll note that the area that we're doing the image on has been collimated to. So the computer will only look at that specific information within the boundaries of the collimator to gather the data that it needs to create an image. The image will not appear as an elbow as it does here, but as you see to the right, intensities. So we're recording signal intensities. Once we record the signal intensities, how we optimize the image with our instrumentation is a decisive factor in determining the best quality images. Let's take a look at the signal that we have acquired to the left, a little squiggly line, and you'll notice that we're reading the intensities of that signal. As we read the intensities of the signal, what we do is get a correspondence of intensity to a grayscale that is located on a lookup table that we correlate with the original intensities. This is called raw data. The raw data is stored in the computer in rows and columns so that we can go back and take the stored data and manipulate that data. Here the graphic shows the input for data on a color monitor. Notice red, blue, and green are the primary visible light colors used on a color monitor. Combinations of these make all colors that there exist. We want to take a look at the grayscale down below. And on the grayscale down below, what we're looking at is the intensities that are recorded in what is called a histogram. It's nothing more than a two-dimensional graph of the intensities. We then choose the intensities that we want from this histogram based upon our input and create an image to view. Every image to be created has to have chosen parameters, and this is usually done automatically through our computer system based upon anatomical positioning and the AEC. Radiographers utilizing portable equipment can go almost anywhere in the hospital, and they interact with lots of patients and lots of hospital employees. So we have to worry about the spread of infectious agents or organisms. They include bacteria, fungi, viruses, and parasites. Healthcare workers have a high risk of contact with infectious agents due to the various types of activities involved with their jobs and the possibilities of contamination working with and around the patients. Although it is possible to prevent or reduce healthcare worker exposure to health hazards, healthcare workers continue to experience injuries and illnesses in the workplace. Causes of non-fatal occupational injury and illness with healthcare workers are among the highest of any industry sector. Back in the day of film screen and portables, we used to swap out protective gear all over the place. gloves, thyroid shields, vests, skirts. All of these were just basically available for someone to use for each and every exam. You just had to pick it up and put it on. What we didn't really think about was how clean are these protective gear that we're throwing on our bodies. I mean, if you take a look, which we did, at one of the hospitals, we did a examination where we took swipes from lead vests, thyroid collars and all to see how much bacteria and other types of elements such as blood, etc., are on the protective equipment. And believe me, they're gross. So the idea here is, realistically, in your facility, do you sanitize or clean your PPE that is shared among the employees? If not, you are basically just picking up all the contamination that the person before you acquired when wearing the equipment. One of the big differences between film screen and digital imaging that is used in this era of the pandemic is the amount of draping and cleaning of the machine, and also the amount of protective gear that is disposable that the operators must don for each examination. There is a complete different methodology in how to dress specifically for each and every patient. There is a difference in the equipment going from room to room to room. During film screen, we're supposed to clean the portable in between each and every examination. To be truthful, we hardly ever did unless it was like a hazardous area of, a restricted area because of Ebola or something like that. But today, with COVID, it makes a big difference. Every time you touch a patient or a image receptor or the equipment, you're spreading infection, disease, and germs. So portable exams take more effort than the exams in the past, and therefore they're taking more time if done correctly. If not done correctly, and we do them just like we used to, we're spreading a lot of disease all over the place. In the past, time, distance, and shielding were the big safety factors when doing imaging with ionizing radiation, because we were trying to protect the patient and the healthcare worker from ionizing radiation. That has increased today because we need to have an emphasis not only on time, distance, and shielding, but also infection control. Interestingly enough, we're also doing more portable examinations today than we used to do in the past. Because of the possibility of COVID infection, we're going to take a chest examination or a quick look at the chest x-rays of patients that possibly have COVID prior to bringing them down to the medical imaging department to do other studies on medical imaging equipment. So, the portable becomes the first guard in making sure that we're not spreading disease and infection among medical imaging colleagues. It's most important for the operator or the radiographer performing the exam to make sure that the infection control is a standard part of each and every procedure that they perform. Let's examine this image very closely. Here we have a parking station for a portable x-ray unit. Notice that the portable x-ray unit is parked on a pad. What this is for is to try to keep the x-ray equipment, once it's cleaned, from picking up dirt and other types of things off of the floor. We're going to have to clean the x-ray equipment in between each and every use, theoretically, but at least we need to clean it thoroughly when we bring it back to the station where we are parking it. You'll also notice that on the X-ray equipment here that there are drapes over much of the equipment for areas which the radiographer would be touching. What this helps with is the fact that you don't have to keep cleaning those areas over and over and over again. You simply need to change out the drapes as needed. We'll see that the radiographer is wearing a protective apron, and over the protective apron she has another apron which is disposable. She also has gloves and a mask. You may use several pairs of gloves during an examination. Anytime that you touch something that you can contaminate the next object that you're coming in contact with, you need to change your gloves. Facilities should establish and comply with a system specifying procedures to be allowed or followed for cleaning and disinfecting equipment after contact with blood or potentially infectious materials. You need to comply with all federal, state, and local regulations pertaining to infection control. And you should comply with the generally accepted guidance on infection control. And we know that that sometimes doesn't happen as much because we're busy. But in reality, a step in time, or how's that go? A stitch in time can save you 9. Infection control, although we do not see the results, is extremely important. Take a moment to read this portable chest X-ray protocol designed for use with patients that have COVID-19. Notice there is a specific methodology in actually doing the examination for infection control that is in addition to doing the examination to get the diagnostic information that you need. Some of the protocols actually have you doing the examination outside of the room with the patient standing and the door open or through a glass partition. But let's look at entering the room. Prior to entering the room, you need to make sure that you have all of your protective equipment, disposable and for ionizing radiation, on and available. Notice the first thing that the person's going to do is touch the door with those gloves. Remember, that's an area that can have lots of contamination. Should the technologist or radiographer change their glove that they just used when touching the door handle? When you enter the room, assess the environment for placement of your portable X-ray machine. Greet the patient and explain the exam, including the infection control procedures. I used to hate the idea of people walk in to do a portable examination, not really interact with the patient, go ahead and slide a cassette or imaging receptor behind the patient, throw on a lead vest, make sure everybody was out of the way, got at least 6 foot away or outside the door, and then yelled at the top of their lungs, "X-ray!" just so other people wouldn't get any ionizing radiation, and then leave. The patient, meanwhile, has no idea what was going on and thinks that, boy, that ionizing radiation must really be dangerous because they're scurrying out the door, yelling X-ray, and getting everybody out of the room. Perception is a big part of how you conduct the exam. If you explain and work with the patient, you'll alleviate many of their fears and the exam will be much easier to accomplish. Positioning the portable unit and setting up for the exams. I kind of got even with nursing because I married a nurse. Unfortunately, she was one of the biggie head nurses, And what we found is that every time X-ray had gone into the room and left, it was a convenient thing to go, oh, that went wrong? Well, of course, those X-ray people were in here. They actually, took the IV out, or they did this, didn't do the oxygen. Being able to work in the room and knowing how to work with the equipment in the room, the bed, the oxygen, the IV stands, etc., makes a difference. All of that has to be done correctly. It's not just capturing the exam or the information. It's capturing the information with doing the least amount of disruption to the patient and the patient's environment. It is obvious that transmission of infectious materials will acquire most when you're actually having physical contact with the equipment and the patient during positioning. The image receptor needs to have a sterile cover each and every time you make an examination or exposure. You need to change your gloves each and every time you interact with the patients or touch the patients and the equipment. After completing the exposure, the drape or the cover for the image receptor needs to be disposed of and a new cover for the next examination applied to the image receptor. Proper infection control adds a lot of steps and work to each and every examination. To do the exam correctly and to maintain a sterile or aseptic type of technique takes time. Also, disposing of the contaminated materials that are disposable makes a difference. Where do you take the image cover that you've just had over the image receptor and dispose of it? In addition, we have to look at how do we change when we go into the room to make sure that we have the disposable gown, gloves, and mask, and how we change and dispose of those after the exam. Remember, after the exam, many of the gowns and gloves and masks we wear are possibly contaminated, and they need to be disposed of correctly. So there is a process for you to understand how to dispose of the disposable gowns and gloves and where to. After disposing of the disposable gowns and gloves, we must also then wash our hands and get ready for the next exam. Suppose there was an error, patient motion, whatever. What about repeat exams due to error? How are these accomplished? When are they accomplished? And where are they accomplished? In some of my past lifetimes as director of radiology or as the imaging clinical director for the X-ray school, I find that people have a lot of excuses for errors in medical imaging. The one thing that seems to be the most common is the idea that it's usually not the X-ray machine that is the problem. When it comes to radiography errors, one single mistake can have a far-reaching consequence for both patients and practice. We need to be aware of our errors and be able to fix those that we can and repeat the examination if we cannot. Understanding your equipment from the X-ray machine to the image receptor and how the interaction of ionizing radiation occurs with tissue will allow you to get a better idea of how to correct for errors or see where the errors actually happen. It might be in the signal to noise radiation that you're using. If you don't have a strong enough signal, enough radiation, you're going to end up with quantum model or a salt and pepper look to your image. If you have too much radiation, you're going to flatten the image. You're going to lose some detail. Remember, image quality is the perception. We're recording an image and we want to look at sharpness and resolution as well as contrast. Well, let's take a look at some of the reasons for a repeat examination. They can be positioning, overexposure, underexposure, wrong exam, motion, and many other factors can actually impact upon the image and cause a repeat examination. So when we're doing the examination, we need to be on our toes. The term event actually is a term used for inspection by the Joint Commission, and what it reports is each event or activity that needs to be documented. Wrong events not only occur in the operating room, but throughout the hospital and in radiology. Errors in radiology are similar to those that we see occurring in the operating room. Wrong patient was x-rayed because there were 2 Marys in the department that day, the wrong procedure was performed, on and on and on and on. So we have to look at the multiple factors that affect the wrong patient, the wrong procedure, the wrong side, and the wrong site. In my past, I was the clinical director for a radiography program in the Houston Medical Center at a large trauma hospital, one of the largest trauma hospitals in the United States. A lot of the actions that happen very rapidly and where you have to make decisions very rapidly and where their errors can occur happen in trauma. Because in trauma, you never know what or who will come through the door next. Many trauma patients require portable exams in the emergency department. When they're ordering the exam, it's just not ordering an x-ray. They need to be, the physician, knowledgeable about what type of exam is best for that particular patient. Do they have the imaging resources there to produce the exam? And how will the facility get reimbursed for the patient's care? All of those go into the decisions of the emergency room doctor. For the radiographer, what we have to look at is our request. Was the request filled out correctly? The right patient, etc., etc., etc. All the demographics. Did the request have the information that would help the radiologist or interpreting physician in diagnosing the examination or the image? What we look at here is the fact that how many times have you gotten an x-ray image request that says x-ray for pain? Well, that doesn't do a whole lot, does it? Or how many times have you got a request that says x-ray the right knee, and you take a look and it's the left knee? Now, realistically, in the emergency department, they need to write a new prescription or imaging order for that. Of course, they don't want to do that. It is illegal for you as an x-ray radiographer to take the original order and change the right to left. So you need to really get together with the folks and start working as a team and exchanging the things that need to be done correctly between the two of you so that you can get the exams done quickly and correctly. Let's take a look at the different categories of trauma patients. Category 1 is a severe injury that will benefit from a trauma center care. Category 2 is a significant mechanism of injury that may benefit from a trauma center care. and category 3 is a minimal potential for severe injury and should be treated at a local hospital. Well, what are we talking about? A trauma center, local hospital, and all that. We have different categories or a hierarchy of hospitals that we can take trauma patients to, and we'll go over that in just a moment. Once the patient gets to the hospital, we have things under control, but how about on-site? Working for a number of years as the clinical director for the radiography school and working in major trauma hospitals, one of the things that the radiographer needs to do is to understand which exam should be taken in which order. You may have something that looks really gross, but it can wait. And you may have something that doesn't look too bad, but if you don't get the examination in time, the patient could die. Taking a look at these images here, which one, if found, is a lifesaver, and which one, if missed, could be a terminal. As you are doing the examinations, you need to assess this in the order in which you take each examination. Now let's review the type of care that is available in these hierarchy of trauma hospitals or hierarchy of medical availability. We have a level 1 and a level 2 trauma center. A level 1 trauma center is usually a university or teaching hospital in a large metropolitan area. To become a level 1 center, you must treat at least 1,200 admissions or 240 major trauma patients per year. Where I worked, we do that almost per day. That's kind of an exaggeration, but tremendous amount. We had the military bringing their physicians in for training, and the reason they were trained at our hospital is we got more car wrecks and gunshot wounds and whatever than they ever found in Afghanistan during a day. Anyway, on with the show. A level 2 is basically the same thing as a level 1, but it's not a teaching hospital or a research hospital. And it is usually on weekends that these hospitals see the most trauma. Now we'll look down at how we triage the patients to lower level hospital systems. In other words, do you need to go to a level 1 trauma center when you have a sprained ankle? Obviously not. We have level 3 and level 4 trauma centers. A level 3 trauma center is one that can transport the patient to a level 1 when necessary. And it usually happens to be in smaller towns or cities where you have 24-hour-a-day availability of trauma care. A level 4 may not be a hospital. It could be an emergency center. Here we can stabilize and send the patient to a larger trauma center. They're usually found in remote and rural areas, and the people that work there have on-call nights and weekends for different specialties, meaning that they don't have someone on staff at the time the patient arrives. What is the radiographer's role in working with the trauma or the ER healthcare team? The first thing is you have to perform as part of that team. When you're doing emergency type x-rays, they want an experienced tech that can perform quality diagnostic images as ordered and bring the images to the physician quickly. You need to possess the skills to think quickly and produce images that are both diagnostic and timely. I used to say you should be able to do an entire manual technique chart in your head and know alternate positions for every part of the body, and then you need more experience to be able to work in trauma. Anyway, you also need to have practical, ethical radiation protection knowledge and skills. Remember, we're using low dose ionizing radiation to get these exams. We have programs that you can access that will talk about low-dose ionizing radiation and its effect on both personnel and patients. But to be very simple, unless you get a massive amount of radiation at one time, it's pretty darn safe. So you want to practice ethical radiation protection, but you also do not want to slow down the process of gaining the information. And you have to be able to provide competent patient care. And this goes to the fact that you need to understand what types of different oxygen levels, how to get the oxygen to the patient, what are the different types of ancillary devices that you can use. There's a great deal that goes into doing trauma radiography. It's just not like going to the room, doing an x-ray and going, oh yeah, I'll go there and do a portable. Doesn't work. And if you're not able to perform well, believe me, they won't ask to have you back as part of their team. It's not as hard or complex as it sounds. Acquiring good quality images should be something that you do routinely, regardless of the acquisition technology. Good radiography images can be produced only when certain fundamentals are met. It's very simple. If you do basic X-ray well and understand the principles of X-ray, you can succeed in any imaging environment. Well, let's look at the differences between film screen, again, and digital imaging portables, because we have to analyze these, especially when we're doing trauma work, but all portable images need to be analyzed prior to going on to the next exam. When we do an electronic image or a digital image, we lose visual cues that we normally see in film screen. When we look at the image on the monitor, we're looking at a different type of image than when we looked at a film with an image on the film. Digital imaging has wide dynamic range. In other words, we record much more information, and that information is automatically rescaled by the computer and processed. The relationship between radiographic factors and image appearance that we used on film have been decoupled. In other words, mass does not necessarily equal density and brightness control, and KVP does not necessarily mean a contrast control. The physics of digital imaging are more critical than what we used to use in film screen because we have more information and more choices. One of the primary things a portable radiographer needs to understand is tube part image receptor alignment. What we're looking at here is I can get any point in your body using an image receptor and an X-ray machine as long as I understand how to align them. Remember, patients that are portable exams definitely are not what we used to call walkie-talkies, not like having somebody walk in that's totally well and let's go ahead and do a chest X-ray. They're in the hospital or the emergency room or the ICU for a reason, and they cannot move as well as they could if they were not in this situation. So two-part film alignment and that knowledge of two-part film alignment is essential in portable radiography. The one thing that is difficult to teach, especially on portable examinations, is experience. You may have the knowledge, which is essential, but you also need to gain experience to be competent in doing a portable examination. You need to understand the anatomy, physiology, and patient care. You have to be able to work as part of a team in a different environment outside of medical imaging, whether it be the ICU, the surgery, or the trauma area. You need to be able to understand the equipment that you're using and all the ancillary devices associated with that equipment. You need to understand positioning and alternatives to traditional positioning to get the information required for the examination. You need to understand both manual and automatic technique exposures. And you need to do pre and post processing of the images prior to them going to the doctor for interpretation, which again means understanding the digital imaging capture process and post-processing. Let's make that a little bit clearer. Here I have two images. One is an image basically showing the raw data that was captured, and two is the image showing when it has been post-processed. As we know, ionizing radiation interacts with the patient's body, and what is called remnant radiation is what we record to make our images. The raw data that we get is very flat, as you can see in the image here. To be able to get the contrast, we need to take that raw data and marry it to a lookup table, which is for a specific position and body part. It gives us the contrast and brightness that we need. You'll find that there is a histogram that is usually displayed, and we can take a traditional H&D curve and manipulate that over the histogram, which is a recording of the amount of intensities that we have, a graph, to adjust the contrast and brightness. So post-processing is important to optimize the captured image. In portable radiography, whether in trauma, surgery, or up in the patient's room or the ICU, we have best practice to aim at. That means to be able to do the exams quickly, with great accuracy and quality, positioning the patient correctly, and practice standard precautions for infection control, and being able to immobilize the patient to restrict movement and decrease the amount of repeats. As a radiographer and doing portable exams, they must be done with professionalism, which means you need to understand what your scope of practice is. Very simply, the scope of practice is what we taught you at X-ray school. We did not teach you to be a nurse, and we did not teach you to be a physician, and we did not teach you to be a transporter. We taught you how to perform X-ray. To do this, you need to anticipate what needs to be utilized during the exam and pay attention to detail while doing the exam. Portable exams are inherently more difficult. Now, if we take a look at the image on the left, remember we talked earlier about tube part film alignment? Do you think there will be some distortion as this image receptor has a poor relationship to the tube and its alignment? Not only that, when you take the exam, we have to think about things like the patient needs to be totally upright at a 90-degree angle to get air fluid levels. If we're not totally upright, the air and fluid will spread out over the imaging area. When we put the patient in for a decubitus view, we need to leave them in that position for 5 to 10 minutes to allow air to rise and fluid to fall. There's a lot that is incorporated in doing a quality portable examination. We can capture an image, but is that image reflecting the information that we were sent there to gather? In the last few years, there's been a difference in emphasis upon radiation protection. Previously, it was sort of like, if you get 1 photon of energy in there and it actually hits the nucleus of the cell and gets to the DNA, you can cause cancer. Well, what's the probability of that? Realistically, using low levels of radiation, as long as you're doing the exam correctly, not being cavalier, trying to use the minimum amount of radiation to get the proper examination or exposure, and matching the exposure to the information that you need to capture. So again, those in medical imaging have always known that draping the lead apron over a patient when getting an x-ray, or over the patient at the dental x-ray, doesn't really lower their risk of receiving cancer. First of all, you should collimate to the area of interest. You shouldn't have the area of exposure so wide that you have to have a lead apron or some other type of shield in front of the patient to protect them from the ionizing radiation. The remainder of this presentation is going to deal with portable fluoroscopy and C-arms. What is a C-arm? It's a semicircular shaped arm that has an image receptor on one end and an X-ray source on the other end. We're going to look at multiple types of C-arms during this presentation. Some will have image intensifiers that were used in both digital but also in film screen. Some will be direct digital receptors. But all in all, the idea of the C-arm is the shape of the arm is in a C, so we can get it around the patient, and we have the image receptor fixed at one end and the image source at the other. The C-arm can do both diagnostic 2D X-ray, 3D X-ray, digital X-ray, and fluoroscopy. It also has several different operator controls so that you can utilize the minimum amount of radiation to produce the best quality image, and also be able to maneuver the C-arm easily in places such as surgery. For a C-arm, conventionally, the workflow is as follows. The conventional X-rays are taken to show the injury, a CT scan or an X-ray, and this information is then used to plan the surgery. At the end of the operation, the C-arm images are taken, and if these show a problem with the fixation device or whatever they're doing surgically, we can go ahead and continue the surgery to adjust so that this surgery is documented well by either X-ray or fluoroscopy. In surgery, the C-arm is an assistant to the physician that is doing the examination. You are under the direction of the surgeon and not the radiologist during surgery. Interestingly enough, it is important for you to fully understand the C-arm functions and capabilities, because you are the imaging expert in a surgical procedure, not the surgeon, not the nurse, and not the surgical tech. You need to be able to position and create exposures while providing the least amount of radiation for the patient and the surgery crew. The radiographer is responsible for protecting themselves and all persons in the OR and special procedures areas from radiation. They're also expected to be knowledgeable concerning the areas that are sterile and how to maintain sterile technique and protect sterile areas without contaminating those areas during the imaging process. So let's take a look at the X-ray equipment in the OR and the use of the mobile C-arm. Prior to even doing any type of examination, the radiographer is responsible for making certain that any radiographic equipment used during a special procedure or a sterile procedure is clean and dust-free before use. That means being able to go through and inspect the equipment. On a C-arm, sometimes you have to take and maneuver it through its different positions to make sure that there's no blood that has dripped and got caught in the rail that you cannot see. So you need to be able to clean the entire piece of equipment in between patients to get a sterile type of examination. So if we had any fixed overhead units in the surgery that we are using, like a C-arm that is extended from the ceiling rails, or we bring a portable C-arm in, we need to make sure that it is clean before the examination. Sterile technique must be maintained for all items and persons involved in an invasive procedure. If possible, we'd like to be able to get the equipment in place and maybe take a scout film or a scout image prior to doing the draping of the patient for the procedure. If the image receptors must be placed after the procedure is begun, the radiographer must pass the image receptor to the scrub nurse, who receives the image receptor in a sterile plastic bag and places it at the radiographer's direction. If the radiographer places the image receptor themselves, the surgical team must make room for them, and they must not contaminate the sterile field. Working in surgery, as in working in trauma, takes different types of knowledge and skill sets than we have in the medical imaging department. Radiophobia. Until the last few years, people didn't really look at radiation in its true perspective of low ionizing radiation being applied. So again, they told you the best place to stand when doing fluoroscopy is behind the physician, because that will give you an extra shield. So you can see here how we have everybody lined up so the person in front of them is getting the brunt of the radiation that's being transmitted. Or we have some portable shields that are in the emergency room to stand behind, and notice that the nurse has a lead vest, a thyroid shield, and is standing behind the portable shield. Again, when we're working in a surgical environment or with a C-arm, we do need to wear the lead vest and PPE correctly. Fear of radiation is entrenched in the collective psyche, and many people are surprised to learn that the shielding can cause problems. Well, what am I talking about? Let's get a simple example. The surgeon is wearing gloves, surgical gloves, that have some radiation protection in them. When the surgeon puts their hand into the direct beam, what happens during fluoroscopy? Well, first of all, you're never supposed to put any part of your body within the direct beam, but say your hand does go into the direct beam, it is going to automatically increase the radiation because there is more to transmit through. I used to say the bigger the fatter, the more the scatter. Anyway, those are simple things that we need to look at just from a radiation perspective and setting the room up correctly and being able to instruct the people how to use their PPE for radiation safety correctly. As we alluded to earlier, patient size increases skin dose and scatter radiation. The skin dose in larger patients and the level of scattered radiation are two factors that affect the dose of radiation received by both the patient and the surgeons. Therefore, it is important to use additional protective devices or keep a safe distance from larger patients. Your distance, or the inverse square law, is probably one of the things that makes the biggest difference in the amount of radiation that you're going to receive. Let's take a look at how the distance from the radiation source makes a difference to the people working in surgery. First of all, the radiation source is the primary radiation. See, we can see the X-ray tube down underneath the patient. And it's almost like a candle. The closer we bring that X-ray tube to the patient, the more intense the radiation. The closer the image receptor or image intensifier is to the patient means that the X-ray tube is farther away and we get less radiation. What we're doing is we're recording the radiation that is scattered from the patient, and we're receiving the radiation that is scattered from the patient. The dose that goes into the patient, if you're standing approximately 1 meter away, what you get is 1/1000th the actual dose that we're using on the patient at that time. And the idea being that the radiation goes into the patient, it is then scattered from the patient, and by distance we're getting 1/1000th the dose if we're a meter away, and we're wearing, in addition to that, protective equipment, lead vests, thyroid shields, and eye shields, which takes out or blocks 99% of the radiation that may actually get to us. Obviously, different procedures require different positioning for the X-ray tubes and the image receptors. What we need to do is plan the type of procedure that we're going to be doing and the position we would like to put the X-ray system in. For the surgeon, sometimes they think that if they stand directly opposite from the X-ray tube, they're going to get more radiation, so they stand next to the X-ray tube to perform the operation. This is wrong, because you're getting scatter from the patient and scatter from the X-ray tube. On the other hand, if you were standing on the side of the image receptor, the radiation has to go from the X-ray tube into the patient and travel through the patient, and you're getting the remnant radiation that is exiting from the patient, and dependent on how far you are away from the patient, that X-ray falls off dramatically using the inverse square law. There are a lot of factors to consider when positioning the C-arm. So basically what we're looking at is the position of the C-arm, but also what other tools can we use on the C-arm to get an exposure and also minimize radiation dose to the patient and the surgical team. Well, obviously one of those would be using pulse acquisition imaging. What we're doing here is we're not getting a continuous stream of X-ray to create the image. We're getting pulsed imaging, which is reducing the radiation. We need to collimate down to the area of interest. There's no sense in spreading radiation all over the place for the patient and for you. Collimating the radiation keeps it to an area of interest that we are looking at. We need to understand patient anatomy and how X-ray dose is absorbed in the patient's anatomy. Remember, different tissues have different sensitivity to radiation. We need to select a dose rate that's in line with the patient size and maintain distance from the patient and use different techniques like last imaging hold in fluoroscopy to minimize the amount of radiation for the patient and the surgery team. As a part of the surgical team, there is a difference in where they will stand between the rotating nurse, the surgical assistant, and the surgeon. And also, that means there is a different amount of radiation that each will experience. So which part of the body is most exposed to the radiation during surgery? It is usually going to be the hands. Okay? Hands have the greatest risk of X-ray exposure, but the hands have a different sensitivity to X-ray than, say, the thyroid or the eye. Remember, radiation interacts with different tissues based upon the sensitivity of the tissue. The number one thing for any operator or person working with radiation that is not the patient is stay out of the X-ray beam or the fluoroscopy beam. Don't put your hands in the fluoroscopy beam unless absolutely necessary for the procedure. As we discussed before, having gloves that have some radiation protection in them would drive the radiation dose up higher. And here we see radiation dose to the hand from one of the original users of Roentgen rays back in the day, one of the radiologists way back when they didn't know better and they didn't protect themselves, but actually put their hands in the beam to manipulate the patients and actually used their hands as a filter to actually filter or reduce some of the radiation to the patient. Do you have standards or procedures that are suggested for your operating room personnel and that they know? Like if multiple exposures are taken, all personnel who are not scrubbed must leave the OR if possible. The scrub members of the team must wear protective radiation apparel, and they must also step behind protective lead screens when available. When hands are directly exposed to radiation, leaded sterile gloves as well as other protective equipment must be worn. Pregnant female personnel should not be present in the OR when the radiographic imaging is in process. Obviously, the radiographer must wear his radiation detection badge on the outside of the lead apron and under the sterile gown during the procedures. The badge must be checked at the prescribed intervals for radiation safety programs. During imaging, all unnecessary instruments must be removed from the operative field and a sterile drape must be placed over the incision. By leaving instruments in the field, it's the same thing as having your hand. The fluoroscopy would go up, it would meet something that it needs to transmit through, which it cannot, like a surgical instrument, so it's going to increase the amount of radiation trying to get through that surgical instrument. These are some simple protocols that should be in place, but are they? At times you may feel with the environment that you're working in, especially if you have a small room, moving the C-arm equipment and the X-ray equipment is Similar to trying to back a semi-truck into the loading dock. I mean, you got to know how to drive that equipment. So we need to take a look at the range of motion for a C-arm, which is different than the range of motion for an overhead X-ray tube crane. You also need to understand how the procedure is performed that you're imaging so that you can place the equipment correctly and utilize the equipment as needed as part of the operating procedure. Physicians performing fluoroscopy-guided procedures should be aware of the potential for serious radiation-induced skin injury. Remember, they're not going to see the skin injury immediately, and they don't have the training that you do. I used to have to help train the residents how to do fluoroscopy. And one of the things they do is keep their foot on the exposure pedal and slowly look at everything. Well, what's happening during that time? They're exposing everyone, themselves and the patients included. Whereas they should just tap on the fluoro and take a look at the images as they go. Also, because they're not aware of radiation-induced damage based upon the amount of radiation over the period of time that they're using the radiation, they tend to use large doses of radiation and use the equipment for not minutes, but hours upon hours in some of these procedures. The biggest overexposure of radiation using low ionizing radiation, the biggest dose usually is a physician utilizing fluoroscopy that is not familiar with radiation safety. Because people in surgery are only interested in doing that procedure at that time, and they are not aware that radiation can be cumulative, radiation dose can be cumulative or is cumulative, they very rarely look at what the patient had done before. You need to understand what different procedures the patient had done previously and what types of C-arm angles were used so that you're not irradiating the same area of the skin again. Remember, there are different angles that are used in cardiology. But if you come in for 1 or 2 or 3 or 4 or 5 different procedures for heart cath, you're getting not 1, but 5 different procedures with 5 different types of radiation dose, all of which is cumulative. It doesn't hurt the imaging personnel, but it does impact on the patient dose. So it's imperative to get the experience and the knowledge about surgical procedures and using imaging technology in these procedures prior to doing an exam in surgery with the C-arm or X-ray. Let's take a look at not only the imaging environment for getting the correct image, but what surrounds it. What is the environment that we're working in? Here we can see that there are a number of things that the radiographer needs to be aware of for each and every surgical suite and what type of surgeries are being performed. This is an endoscopy suite. What we can see here is a number of different pieces in the picture that you must be aware of and how to work around. Everything from the anesthesiologist to the ECG machine. What about working in the OR environment is different than working in trauma or the ICU or the NICU? Well, when you're working in OR, the main thing is it requires a super awareness of sterile environment. You need to be skilled in the use of your portable machine and C-arm. You need to be able to place the equipment correctly and in the most efficient manner around the OR table, which houses the patient. You need to know anatomic landmarks, whether you can see them or not, for your imaging. And you need the ability to work with the surgery staff under high pressure circumstances. Remember, as long as everything is going great, not a problem. But when things start going wrong in surgery, the surgeons tend to get a little testy. Okay, let's see what happens when things don't go right in surgery and basically you're working with a surgeon and a surgery crew under stress. First of all, you need to realize that you do not work under the direction of the radiologist at that point in time. You are working directly for that surgeon, who, if he's stressed out, may appear to hate you, especially if they don't know you and haven't worked with you before. Often you'll find surgery crews want the same radiographers to work in surgery over and over again because they're confident in those radiographers' skills. You must be able to perform accurately and quickly, and repeat is no longer in your vocabulary. You got to get it quick and you got to get it right. Remember, it's a high-stress situation for all, but success or failure rests on the surgeon's shoulders. Also, what we need to look at is interaction of people. Remember, every hospital, every department, every shift has different people working together, and they form a specific culture for that group. When you go into surgery, remember, you're not part of their group, and therefore you're not part of their culture. A unit or facility's personality is how things are done here. Assumptions, values, and norms are based upon the group that you're working with, and you can't assume that they know anything about radiation safety or imaging. You need to work in harmony with them and become part of their team. So a quick overview of interoperative radiography. First, it requires superior technical skill. Technologists work under the direction of a surgeon as opposed to a radiologist. The radiographer must have the necessary skills, including aseptic technique, mobile radiography, radiation protection, communication, which is a very big skill, anatomical landmarks and pathological findings, being able to recognize those. And you must be able to perform accurately and quickly during the examination. It is imperative for anyone working in surgery, and especially for radiographers or other people that are not part of the surgery team that come in to work during a surgical procedure, to understand sterile technique and sterile versus unsterile, and sterile areas versus unsterile areas. The radiographer must be able to work in harmony or together with the OR staff, especially when it comes to setting up the rooms and draping the equipment. A sterile field ends at the level of the tabletop or at the waist of a sterile person's gown. Anything that drops below the tabletop or a sterile person's waistline is no longer sterile and may not be brought up to the sterile tabletop. The only parts of sterile gown considered sterile are the areas from the waist to the shoulders in the front and the sleeves from 2 inches above the elbows to the cuffs. The cuffs of the sterile gown are considered non-sterile because they collect moisture. Cuffs must also always be covered by sterile gloves. When working with the staff, the radiographer must communicate or explain and demonstrate how to drape the equipment for sterile technique. I can't emphasize enough how important it is for the radiographer to understand the type of exams that they are going to participate in and their role in that examination. You need to be able to understand what you're doing, how you're doing it, and why you're doing it, which means you need a knowledge of the different types of surgery and how imaging is used in those types of surgery. So we'll take a look at some here. Here we see a hip pitting in the AP or anterior posterior position. But we need two 90-degree angles, right, to know exactly where something's positioned. So do we need to do something? Yeah, we actually need to swing the C-arm into a rainbow or a 90-degree from vertical position to be able to see the lateral view. Here we can see the lateral view for the hip pinning. Now, notice we're going to have to move the equipment. And how do we move the equipment into position without impacting on the sterility of the field that we're working with or the position of the people that are doing the surgery? This image shows doing abdominal surgery. So you'll notice the position of the C-arm and also that the C-arm is sterile draped. There's a clear plastic cover over the image intensifier in this, and if we were using a DR or a digital, we would have the same type of draping over the image receptor. Another common surgery is a Hickman catheter placement. You position the C-arm in a position that is up at the top, in other words, for the Hickman catheter placement, and the introduction of the catheter begins in the upper thorax. We may start with the rainbow position or the 90-degree from vertical position when doing something like a cervical spine surgery. We always need at least a minimum of two 90-degree views when we're doing surgery to be able to see the placement of what we're doing and how we're doing it. We may have very many angles that we use during the surgery also to be able to visualize how to best do the operation. Very simply, we need to be able to position the C-arm over the anatomy and know all of the range of motion of that C-arm and be able to utilize it without breaking sterile technique. In some cases, this may be the initial position of the C-arm is under the anatomy as opposed to over the anatomy. Understanding each one of the surgical procedures and what you need to image is going to determine how you set up and place your equipment. In surgery, we may be doing open reduction or closed reduction, or what we're going to be doing is allowing the surgeon to manipulate the patient's anatomy either with the incision and opening up or to use closed reduction and just manipulate it by hand or feel. Soccer game in the upper right-hand corner. What happens to the soccer player's leg? Obviously, that leg at the tib fib is broken and they need to go into surgery. When they go into surgery, they're going to need an open reduction and internal fixation of the bone using plates and screws, which is different than a closed reduction by just manipulating the bone back into its original position and casting it. So what are the risks of using a C-arm in the operating theater? Well, one obviously is the risk of importing infection. Another would be radiation risk to the patient and to the employees. But a third would be risk of explosion. What? Explosion? Yes, when you're using anesthesia, you have explosive gases that settle because they're heavier on the floor. When you plug your equipment in, you'll notice that the plugs are above waist level or higher, so they're above the gases so you don't get a spark and create an explosion. If the plugs were down on the floor and the anesthesia was going and there was gases down there and you plug in the equipment and it caused a spark, you could actually get an explosion. So sometimes there's some weird stuff there that you don't even think about, but can be really a risky type of thing. Let's take a look at using time to reduce exposure. What are we talking about here? Well, when we have an exposure, we have to have equipment. And that equipment produces ionizing radiation. The three tenets of radiation exposure reduction are time, distance, and shielding. The radiographer is going to be in charge of positioning the equipment, and the surgeon will be in charge of the radiation exposure amount and time. So how do we reduce exposure in surgery? When image quality allows, we use lower dose techniques such as pulse fluoroscopy, using a last image hold, doing the minimum amount of fluoroscopy to get the job done. We also limit the use of boost fluoroscopy, in other words, high dose fluoroscopy. And being able to put this into practice will allow the radiologist to get images to read that are quality images, the surgeon to be able to have quality images to utilize during the procedure, and the minimum amount of radiation exposure to both staff and patient. One of the things that the radiographer can do in conjunction with the surgeon is to explain to the surgeon, or whenever the exposure starts, beam on. In other words, the foot pedal has been energized, and beam off, that the radiation is no longer being utilized. Why? Because surgeons are concentrating on what they're doing. They're forgetting about the actual foot pedal and what they're doing there. A lot of times they might end up just leaving their foot on the pedal and creating a lot of exposure that doesn't need to be used. By being aware of the beam on and beam off time, they're able to control the amount of radiation better. They also need to look at the magnification views that they use. When you use mag views, you increase the exposure. We have two different pedals. If you step on the wrong pedal, you're boosting the exposure for a mag view. So again, understanding your equipment, how it works, and having your surgeon understand how the different components that they interface with work make a difference in radiation safety and patient safety. We've gone over this a bit previously, but let's do it formally now and take a look at basic C-arm positioning. On a C-arm, remember, we have an image receptor at one end and an X-ray tube that generates ionizing radiation at the other. If we place the X-ray tube underneath the patient, under the table is not going to move. So we need to raise and lower the X-ray tube to get different types of magnification or geometry of the image. When the image receptor is as close to the patient as possible, the X-ray tube is as far away. This means the patient is getting the least amount of dose. As we raise the C-arm vertically, we're getting the X-ray source closer to the patient and increasing the dose. Also, remember that the dose that the surgeon receives or the X-ray and OR crew receives is not directly from the C-arm and its X-ray tube. It is from the remnant radiation that is scattered from the patient. The closer we are to the patient, the higher the dose of radiation. The farther we are from the patient, the lower the dose of radiation. How you place the equipment, and remember there are different angles that we use, two-part film placement alignment for imaging makes a difference as to the radiation that the surgeon is going to receive. And you should discuss this with them and explain how this works so that both of you can get the best quality image with the least amount of dose to the operating personnel. If we look at the best configuration, we're going to have the X-ray source underneath the patient and the image receptor above the patient. What will happen is the scatter X-ray coming out of the X-ray tube and the patient will go down, and it will get to our knees or lower area, and we do have a lead vest in there to help us protect against that radiation. We keep the lead vest on, and if we reverse the type of configuration where now we had the X-ray source at the top and the image receptor at the bottom, we've just increased the dose to the surgeon by about 3 times. And this includes the dose to the eyes and the thyroid. We have the X-ray protective equipment for both thyroid, lead vests, and eyes, but they would be more needed in a position with the X-ray tube that is vertical or on top of the patient as opposed to underneath the patient. The quality of the image acquired is dependent on the relationship of the beam direction and the target to be visualized. For high quality images, the beam of the X-ray should travel perpendicular to bone with the image intensifier as close to the patient as possible. Let's say we have the C-arm in the lateral position or the rainbow position. We have the photons of ionizing radiation going through the patient. And of those photons that reach the patient, about 20 of them pass through the patient and go to the image detector. About 100 or 200 of them are scattered from the patient, and the remainder are absorbed by the patient. So the patient is absorbing about 800 photons or so of radiation, and the only scatter that's being emitted, which can actually interact with the OR crew and the radiographer, is about 100 to 200 photons. So it makes a difference how you are standing with relationship to the image receptor and the X-ray tube. People wrongly think that if you're standing on the side of the X-ray tube, you're getting less radiation, when it's actually the opposite that is true. Remember, we talked about magnification, and magnification can impact upon patient dose. So as we magnify the image, we get a greater dose. We can see the dose of 100 at a 12-inch or 32 cm magnification is increased up to 300 using a 4.5 or 11 centimeter magnification. The smaller the image intensifier diameter, the greater the patient entrance dose. The most obvious and probably the least used is collimation. You need to collimate down to the area of interest. There's no need, unless the surgeon needs to see a huge area to know where they're at, to over-irradiate the patient or overexpose the patient and cause more radiation to the surgeon and the staff. For the remainder, or the last of this presentation, we're going to take a look at 3D C-arm applications. You know, the difference between 2D and 3D is pretty dramatic, and things evolve over the ages, including X-ray equipment. So we get a more realistic view with 3D than we do from 2D, but there's a price, and that price is the amount of radiation that has to be used. Cone beam CT is a new emerging technology that allows 3D image acquisition using a C-arm fluoroscopy system. It has been reported as a valuable imaging tool because of its good bone and soft tissue resolution. Doing 3D or C-arm CT allows us to get high definition and 3D volume reconstructions. CBCT combines the advantages of conventional CT scanning and image guidance with the involved and improved spatial resolution, patient positioning, and access of fluoroscopy. The difference is that we are going to be utilizing more radiation because we're collecting more data to create these images. Thank you for your time and attention. We'd like to have you review some of our other programs to get more detail and in-depth knowledge about digital imaging and the process of creating images and post-processing images. Thank you once again, and we appreciate your time and your interest.